Shock. Is everybody in shock about the topic of this talk? Sorry, there'll be so many bad shock jokes. All right, let's dive in with our talk on shock. We have done chapters in our textbook, and we've done other screencasts on cardiac and lung and IVC and the undifferentiated shock applications in point-of-care ultrasound are really nothing more than combining those into like a thought profile. You don't actually really learn new techniques, you just learn how to put it all together. So this is a put it all together talk. And our PALS approach teaches us that we should be thinking about a variety of different categories for what causes shock. And what we want to talk about is how ultrasound can be used to stratify people into those categories of cardiogenic shock, obstructive shock, distributive shock, and hypovolemic shock. So when you look at how our current standard of care PALS resuscitation approach guides us into how to categorize these people, it gives you tables like this, that you're supposed to look at respiratory rate and effort and breath sounds and systolic BP and pulse pressure and heart rate and peripheral pulse quality and what the skin looks like and cap refill and urine output and level of consciousness. And these are all things that we do often in 2 seconds at the door, but they're also things where like many of these different categories produce many of the same things, and you're looking for that one thing that produces a different look. And the proponents of using ultrasound here will say, well, you stratify a kid much, much quicker into the right group if you use ultrasound in addition to these things, or if you use ultrasound first for these things. And that's how you categorize kids. And then there's, okay, now you're treating a kid with shock, and your two general approaches to doing that are to use fluids or to use pressors. And our tradition has been, well, the kid's in shock. I'm not entirely sure why. While I work on figuring out why, fluids, 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 and then think about pressors. And there's the beginning of a pushback to that approach. This was kind of the seminal article that suggested a bit of pushback, that there may be increased mortality when we're really aggressive with fluids. People who work in the ICU will tell you, a big part of my job is trying to unload fluid from kids who were septic and just got too much. So maybe we can also be more accurate in our choice of fluids and pressors and when to switch between the two if we integrate ultrasound and some things like looking for the equivalent of sonographic crackles in the chest by having a strategy for when to scan what organ as we give fluids and give pressors. So the key points are to think about the units that are involved in producing shock or in suffering from shock. And so the RUSH protocol, which we'll talk about in a second, tells you to think about the pump, the tank, the pipes. I mean, I like to think about what's going on in the chest. And for me, what's going on in the chest is the heart, the lungs, and the major vessels that go into the heart. And then there's the idea of like sometimes you're going to want to think about adding a fast, looking in the abdomen for free fluid onto these views. But I'm going to argue that that's like a specific kind of patient and not one where like you do that on every patient who obviously has sepsis, for example. So the RUSH exam is the name given to this style of thinking. Comes from adult literature where undifferentiated shock is certainly a much more common presentation to an emergency room than it is in kids, and is a structured approach to looking at conditions in the chest, in the pericardium, in the heart, and in the abdomen that can produce shock. And we know there are things that happen in adults that happen much less frequently in kids or never at all. Like a big part of the RUSH exam is to look at the aorta for signs that this patient may have a ruptured AAA, and we're just never going to do that in kids. And a big part of it is thinking about the femoral vessels and looking for signs of non-compressible femoral vessels that go along with the DVT. And again, DVT-PE is the cause of shock in kids. It's much more rare. It exists though, and we should know how to think about it and integrate it into our approaches. And the thing to keep in mind with the rush exam is it's like the fast exam. How did we get a rush exam or a fast exam? Not by bringing together a bunch of research on the utility of each one of these views and then producing this evidence-based exam. Someone thought, I have invented the fast exam. I have invented the rush exam. I think this makes sense, and now let's test if it does. And there's other ways in which you can generate these kinds of exams and think about what's important. So a group led by Paul Atkinson, one of the emergency physicians really active in the Canadian Association of Emergency Physicians and active in the point-of-care ultrasound in the emergency department world, came at this question from a different angle, from one of, let's build expert consensus on what views are useful and what views are useful when. So must we always go and do the rush exam? Or do you have some core applications you do in cardiac arrest, which is the group on the left side of the screen, and core applications you do in undifferentiated hypotension? And then what views can you consider supplementary, and what views are like additional to that? And so this is a Delphi model that begins to make more of a expert opinion based approach to a shock exam. That next stage would be to test this versus, say, the rush exam for which one helps you perform better, faster. Okay, having said that, you guys know how to look at hearts, you know how to look at lungs, you know how to look at an IVC. So let's run a series of cases and see if we can take shortcuts through the PALS algorithms based on using ultrasound. So here's a fairly common presentation, right? 2-year-old, they have fever, they have cough, and they have some vomiting for 4 days. And then you're called to the room for a sepsis alert because they actually look quite unwell. And they're not really febrile at the moment, but they are tachycardic and they are hypotensive, and their SAT on room air is 96%. And you're now a POCUS user, so you're going to apply your cardiorespiratory exam to them to try to figure out what is causing what. Okay, so I need my fellows to tell me what view of the heart this is. And they say the parasternal long axis. And what's that most useful for telling you about the heart? Function. Very good. So how do they think the function of this heart looks? Good or bad? All right. So we have a good squeezing left ventricle. And then what view of the heart are we looking at here? Subxiphoid, which is your best view for? Effusion. Do we see a pericardial effusion? Oh, we've got a very expert opinion that says this is a limited view, and they're right. Let's say you scan all the way through, you fan through the heart, making it appear and disappear, and you still get views like this. No effusion. Okay. And what view do we have here? IVC, good. And does the IVC look plethoric, collapsed, or somewhere in between? Collapsed, okay. And this view I put in because when I talk about, you don't need the fast exam integrated, but you do need to be doing lungs as part of your view. I incorporate often, I've done my low frequency probe maneuvers that are my cardiac scanning. And before I switch to a linear probe, I just, let's take a look for effusion, right? Often in cardiac failure or other conditions, you may have a pleural effusion. So this is the right upper quadrant. So did anyone in this clip see a pleural effusion? No. What's this? Yeah, and it does not extend above the diaphragm. You just got mirror artifact here of the liver.